So before we start the session, I just wanted to say a few brief words about the sad passing of Dr. Alastair Lascelles. Alastair was a consultant histopathologist who worked for many years at the Western General Hospital in Edinburgh, having retired in 2012 and passed away after a short illness in May 2021. I'm grateful to Alastair's wife for providing the photo, which she pointed out shows part of his notoriously clean desk, and not, I hasten to add, because he did no work, but because of his legendary reporting efficiency. And Alastair was an exemplary pathologist, as anyone who knew him would know. He was my educational supervisor during my training in Edinburgh, and he was a mentor and friend to me, as he was to many others. And he had a significant influence in shaping my own career, not least by introducing me to EQA, about which he was passionate. And in fact, Alastair was responsible for setting up the first EQA scheme in the UK, the South East Scotland General EQA scheme in 1986. And he co-authored a paper in the Journal of Clinical Pathology in 1992 about the 4-year experience of running this scheme, which I've referenced at the bottom of the slide. So I just wanted to formally acknowledge the valuable contribution he made to EQA in the UK. And if you're looking down, Alastair, I'd like to say a personal thank you for the guidance and support you gave to me and many others in Edinburgh. You'll always be very fondly remembered. May you rest in peace. Right, I'll just take a quick second. That was a bit harder than I thought it would be. And now I'm afraid I'm going to turn on the camera as well, so you'll be able to see me. So I'll officially move to starting this and opening this session today, which is the third virtual participants meeting for the Uropathology EQA scheme, where we're going to score circulation AC. We'll use a similar format to previous meetings. I'm going to do the first 6 cases. John Oxley will take over for the next 6, and John Dormer is going to do the 3 prostate cores. Then we're going to have a 10 to 15 minute comfort break, and then we'll move on to the educational cases, which Dr. Lisa Browning from Oxford has kindly agreed to present. We'll have a short break after that, and then what we hope will be a very brief BAUP AGM meeting. So without further ado, we'll move on to the circulation. So we had 418 responses, which is the most ever in this circulation, and there were exemptions in a small number of cases. So the first case was a left partial nephrectomy specimen with a 20 millimeter tumour, and no immuno was provided in this case. So this is a low power shot of the tumour, showing a relatively circumscribed but partially encapsulated tumour, rather blue in appearance, which had an almost uniform, very striking papillary architecture at the low power. In other areas, the tumour had quite prominent foamy macrophages and some hemosiderin pigment in the tumour cells, and a representative high power field shows relatively bland nuclear cytomorphology with basally located nuclei, some cytoplasmic clearing, no somomas or hyalinized papillary cores. So in terms of comments, about 10% of people asking for some immuno, no people saying unsuitable for EQA. And these are some selected comments. A number of people making reference to the fact that JUPs have recently suggested abandoning subtyping of papillary RCC because we're not particularly good at it, and a lot of tumours show overlap with both types. And I think those that are in the know are suggesting that the imminent new WHO is going to drop the subtyping of type 1 and 2 and move to focusing on grade, which is probably more helpful. One person here noting the clear cell-like areas and potentially doing immuno for TFE3. Somebody else suggesting the possibility of clear cell, but making the point that the morphology and particularly the apical placed nuclei were not obvious in this case. Some different requests for immuno. Somebody pointing out that papillary adenoma would have been in the differential, but this was over 15 millimeters and had a partial capsule, which precludes the diagnosis of adenoma. And then somebody wondering about the possibility of a metastatic tumor to the kidney. So these are the responses that were received, and as you can see, very high, almost 95% agreement that this is a type 1 papillary renal cell carcinoma, which was the proffered diagnosis by the submitting pathologist. And then we've got some others. So papillary type not specified. This possibly may include people that are sort of ahead of the game with the WHO and gut suggestion not to subtype. So I think it might be very reasonable to merge, give both these responses one. Clear cell papillary is obviously in the differential, the cytomorphology not quite right. Papillary solid variant, well, this was very obviously papillary rather than having the solid sort of ascena pattern of the solid variant, but papillary nevertheless. So maybe at least half marks, and maybe people think that merits a complete mark. Metanephric adenoma is in the differential as well. And remember, there was no immuno done here, so people may feel that's worth half. Papillary type 2, it didn't have the typical high-grade morphology of type 2 papillary, but that person's obviously made the correct papillary diagnosis, so again, maybe half. And metastatic tumour, that was just a single person there. So first bit of work for you today. Do you think this case is scoreable? We've reached the 70% threshold. And that's pretty unanimous. So we'll go on and let you score that. That should now appear.
Just want to say, Nick, we've had no questions in the background. So yeah.
Yes, sorry, I noticed that. I didn't. So we are monitoring. If there's anything you want us to address, please send in some of the comments, and we'll do that. But you can get on with voting for this case. So I see we're now we're 180 participants. We're over the 100 for voting, so I think we can. I'll give a couple more seconds.
It's going to be a long day, Nick. Let's go for it.
Yeah. Okay. So papillary, Johnny, you can take these scores down. Papillary type 1 is 1. Papillary NOS is 1. Papillary clear cell is 0. Papillary solid variant is a half, just. Metanephric adenoma is a 0. Papillary RCC type 2 is a half. And metastatic tumours is a 0. And the papillary adenoma, I think that was by a trainee. So this is a relevant paper, which I think will be quoted in the WHO, that looked at prognostic factors in papillary tumours and found that ISUP grade and unfavourable architecture were more predictive of aggressive tumours than the old type 1, type 2. So I think that's probably what we'll be moving towards in the future. Right, on to case 2. This is a testicular case, and it's, I'm afraid, one that we made a bit of a balls up on. So as we move on, this was a male of 40 with a history of testicular torsion, no immuno, and this is the section, and the testicular parenchyma was very obviously involved by tubular necrosis and a lot of red cells in the interstitium consistent with infarction. But the majority of people, other than John and myself, spotted that there were some basophilic beasties in the capsular or extratesticular connective tissue. And at high power, these are rather nicely demonstrating, this one's probably got a terminal spine here. So these are schistosome ova that were in the connective tissue around the testis. So we had a few people saying not suitable for EQA, not that many comments, but in the selected comments, we had a lot of people pointing out that schistosomiasis was there in addition to infarcted testis, and that schistosomiasis was not an option in the drop-down menu. The next comment here was that the reporting or the offering pathologist gave up anonymity and is a well-known professor from Barts in London who was very keen that his comment was seen here. So as you can see, he wants he wants to deduct us a bit of marks here, and we obviously cannot score this case because one of the co-diagnoses was not an option in the drop-down menu, which we apologise for. These were the offerings that we got, with the vast majority of people spotting testicular infarction, which was very obvious, and not being able to put down that there was schistosomiasis in the background as well. So I'm afraid this case is not scoreable. So if we can go through the motions of, it's definitely not scoreable because I didn't put the score into Slido. So we'll let you just vote away on that one. But it gives me the opportunity to just emphasize the point about when you're submitting EQA cases, ideally there should be a single diagnosis, because it's very difficult to score cases when there's more than one diagnosis, particularly when you aren't offered one of the diagnoses. And we should have all the information provided at the time of diagnosis by the reporting pathologist. Now, the good news in terms of submitting cases now, as we move to digital, is that we only require 5 rather than 35 H&Es. And that's going to allow the inclusion of smaller biopsies, which we've been quite restricted about using previously. So that we hope that there'll be a bit more variety in some of the cases that we can use from now on. And this is now the 19th circulation using the drop-down menus in EQA Lite, which is quite a lot of cases. And this is the first time that our pre-screening has failed to put in the correct diagnosis. So apologies, but we're only human after all, and we'll try not to do this again. So we'll move on to the next case. This is just before we do that, this is the case submission form in EQA Lite. So if you have a case, you go to the Your Cases function, add in the details, print off a copy and include that in the when you send the slides away, and that's done. Now, just to get back to testicular schistosomiasis, it's actually an extremely uncommon. So I found a few case reports in the literature, but it's as rare as hen's teeth. And in some of the case reports, it can simulate malignancy. So that's obviously a clinical relevance, but an extremely rare condition.
One of the questions we've had to come across: can schistosomiasis actually cause infarction? I think we're not certain in this case. It doesn't seem to suggest it from that, but possibly this man had torsion and then he just had incidental schistosomiasis as well.
That's right, and I did do a search for testicular schistosomiasis and infarction, and I didn't find anything. So I think that probably is right, that it was an incidental finding rather than it having been co-associated. Right, moving on. So case 3, this was a right nephrectomy for a 4.8 centimetre tumour, which grossly was noted to have some irregularities in the external border with the perinephric fat. There was no immuno provided with this case, and there was a supplementary question related to stage. So this is a low power of the tumour. And you can see around this area of the tumour, the interface with fat is a bit irregular, and I'll show you that at higher power in a moment. And this is a fairly representative field of the tumour at a higher power to show a clear cell predominant tumour with quite high nuclear grade and some prominent intervening small vessels. In other areas, the tumour had quite a prominent collagenized and possibly muscular stroma, again with a solid alveolated appearance. There were some areas at the periphery of the tumour that a number of people commented on, wondering whether this might be a vascular invasion, and they may have done some additional stains. And then there was at least one area showing this feature, which is cellular invasion of fat at the periphery of the tumour. So obvious malignant tumour cells infiltrating adipocytes, and they're the same area at a higher power. So in terms of comments, few people wanting immuno, not many people saying unsuitable, and very few really other comments. And then in terms of the free text comments, clear cell RCC and perinephric fat, a few people, but not many, were considering alternative subtypes of RCC. So chromophobe was one tumour that was considered. Somebody wanted a bit more detail in terms of where the block was from and whether it was perinephric or sinus fat, and as I say, was wanting to do some connective tissue stains. And then a comment about the lack of clarity about whether the staging was based on the macro or the macro description, which wasn't specified, but I think as this individual makes the point, it probably doesn't actually matter in this particular case, as we'll see. So this shows a pretty short list in terms of differentials or proffered diagnoses, with nearly 96%, so that's very high, diagnosing clear cell renal cell carcinoma. And then the next most common clear cell with leiomyomatous stroma, or fibromyomatous stroma as it's now being referred to. And just to remind people, for voting purposes, we didn't have any immuno in this case. So I guess it's difficult to completely exclude the possibility of this. Although most of those tumours are sort of good prognosis, some of them have been described as being aggressive with metastatic disease and higher grade nuclear morphology. So I'm not sure that that can be completely excluded given one block and no immuno. And then a few people went for chromophobe renal cell carcinoma. So in terms of the voting, we've certainly reached well over the threshold of 70%. So do people feel that this is scoreable? And we have unanimous 100% there. So I'll let people get on and score.
And there are no comments.
Thank you, John. So we're well into the hundreds there, so we'll move on. So clear cell renal cell carcinoma 1. Clear cell with leiomyomatous stroma, I think, have just about persuaded people to go for a 1 there, so merging 1 and 2, and the chromophobes 0. And for the supplementary question, we asked to stage this tumour. And so on the basis of adipose tissue invasion, it's clearly T3A, and with very high agreement here, nearly 98% for T3A, and then there are a small number of others. So if we move on to, do we think we can score the supplementary question? That's pretty unanimous as well. So let people score away. Okay, let's see. So PT1B 0, PT2A 0, PT3A is 1, PT3B is 0, and PT4 is 0. Okay, on to question number 4. This was a radical prostate specimen, and there was a supplementary question again in relation to the margin in this case. So here is a low power of the slide. So there were a number of sections which at the low power demonstrate quite a large amount of tumour, and up at the inked margin you can see tumour very closely related to the margin, and at a higher power the majority of this tumour, certainly asana pattern 3, there was nothing that either John or myself could spot that looked ductal, and we'll come on to that shortly. But you can see some dark stuff up at the margin that is approximating to the ink, and this is a higher power again to show rather crushed basophilic stuff, which is probably tumour at the diathermized margin. So not many comments on this case. No one really saying unsuitable for EQA. Not that many comments. Some people making the point that you need to see tumour at the ink, not close to it, to diagnose margin involvement, obviously, and people pointing out the practical problem, as we see sort of day to day with these kind of cases, that it's sometimes difficult to decide whether the crushed stuff is really tumour at the margin. But the majority of people thinking it was in this case. And if you are in difficulty, sometimes it can be useful to use immuno in this situation, although it can be a bit more time consuming if you use big blocks in your institution. So this is these are the answers that we were proffered, and virtually everybody called this asana prostatic adenocarcinoma. This is one individual that called it ductal adenocarcinoma, which morphologically it was difficult to find anything really that was ductal. So when we're scoring this case, I guess it depends how mean or nice you're feeling in terms of, because obviously these are both prostatic adenocarcinoma, so we could merge these all together and move on to the supplementary question.
Although, Nick, of course, ductal is a much higher grade, so
that's true, but we weren't grading it in this case. But it's, as I've said, it's difficult to find the ductal pattern. We'll leave that to you to feel how kind you're thinking. So do we think this is scoreable? We do. So I'll let you score away. So 1 for asana prostatic adenocarcinoma, and ductal, I haven't quite persuaded people, so 0 for ductal. And then this was the supplementary question, so margin positive or margin negative, and this is pretty high, so over 400 people went for a positive surgical margin, with only 6 people saying negative. So on the basis of the power of the herd, I think we can probably score this one. See what people think. John, have we any comments on this case?
Nope.
So we'll move on and allow you to score. Okay, we're well over just over the 100. So negative 0 and positive 1. All right, so on to case 5. This was a male of 70 who we were told had widespread lymphadenopathy, including axillary nodes, and had a bladder wall lesion as well, and went to TUR. And we were given immuno in this case. The tumour was melanA and HMB45 positive, and we were given these as scan slides, and GATA3 negative. So this is a low power of the TUR specimen, and this is a fairly representative area with some normal appearing urothelium on the right side here, and then within the lamina propria some tumour, and at higher power epithelioid cells. Not difficult to find mitotic figures. I didn't see much in the way of pigment, prominent nucleoli, clearly a malignant tumour, and this is the immuno, so not subtle mLNA positivity, in a similar distribution for HMB45, and this is the GATA3, so positive in the urothelium on the right, but negative within the tumour. So in terms of comments, a few people wanted some additional immuno, as we'll hear in a second. 7 people saying not suitable for EQA, and a few other additional comments. So in terms of the free text comments, malignant melanoma, could be primary or metastatic, and then this individual being certainly favouring metastatic melanoma to the bladder, but obviously needing some additional history, and in particular is a history of melanoma. Although primary melanomas of the bladder are possible, obviously you've got to exclude a metastasis before coming to that conclusion. This individual highlighting some of the limitations of the drop down, so malignant melanoma, one option, metastatic tumour another, but metastatic malignant melanoma not in the drop down. And then there were a few people that picked up on the immunoprofile and the fact that they would ideally want to see some additional markers to exclude the possibility of a malignant picoma. We weren't told S100 or SOX10 or smooth muscle markers in this case. So I think having had a little read about picoma, it's a bit difficult to 100% exclude that given the immuno that we were given. And this person making the point that it's sent for BRAF testing given the melanoma diagnosis. So quite a short list of proffered diagnoses, with malignant melanoma the most favoured, nearly 95%. Metastatic tumour is a bit nebulous, but we'll assume that people were saying metastatic melanoma. And then a few people raising the possibility of a malignant picoma, which is not unreasonable given the immuno that we were actually given. So there might be a reason for merging everything here, giving everything one, and moving on.
But Nick, always the devil advocate. If we merge 1 and 2, that's 98.8%. So that's definitely I think if we in the EQA put in a perivascular epithelioid cell tumor malignant into the EQA, I think we would probably give people a lot larger panel in order to make that diagnosis. So you could argue that your starting diagnosis in this case, your working diagnosis would be malignant melanoma. It is interesting that maybe 10 years ago we'd all be doing S100s and we wouldn't be doing melanoma, and so we would have got to the diagnosis quicker. I don't know why the S100 was omitted. I'm sure they would have done it.
Okay, so you've heard the arguments, the debate. Let's see what you think in terms of the scoring. So is this scoreable? It's yes, so let people score.
Go on, Nick.
So, sorry, the button was sticking. So malignant melanoma scores 1, metastatic tumour scores 1, and now the epithelioid tumour scores 0. Oh, well, I tried. You have those, John? So on to number 6. So this is another renal tumour, 21 millimetre renal mass. We were given some immuno, CK MNF116 positive, WT1 strongly positive. In fact, both of those strongly positive, S100, EMA and Desmin negative. So this is the low power of the tumour, circumscribed bluish looking tumour, well delineated from the adjacent renal parenchyma. And at high power, a predominant pattern of small, compact, almost solid acini, and then a gland here with a few micropapillary excrescences. That's a higher power of the acina areas, and you can see. You can see the cells themselves are quite small. very little in the way of nuclear pleomorphism. I couldn't find any mitotic figures in this tumour. There were some slightly different areas which were more papillary in configuration, with occasional somomatous calcifications that you can see as well, again with a similar bland type of nuclear morphology. That might be a lymphocyte there to compare the tumour nuclei size, which are not that much bigger than a lymphocyte. So a few people wanting some additional immuno and some other comments, nobody saying unsuitable for EQA. And then in terms of comments, quite a lot of people mentioned CD57 as an additional marker that's positive in these tumours, and CK7 also can be useful in differentiating from one of the main differentials, which is obviously papillary RCC. The other interesting feature of these tumours is that they're often mutated for the V600E mutation of the BRAF gene. Somebody making the point that these are quite rare and that they've not diagnosed one of these before. Somebody came up with the fact that the S100, which was actually said to be negative, in this case is usually positive, which is slightly atypical, but the morphology otherwise was typical of metanephric adenoma, and somebody wondering about the possibility of a MET from a gynae tumour given the presence of nuclear grooves, although I'm not sure that papillary architectures are typical of these, although I'm not a gynae pathologist. So these are the proffered diagnoses, very high, over 98% agreement that this is metanephric adenoma, which was the submitted diagnosis. One person went for metanephric adenofibroma, although the stromal component was quite inconspicuous, but I would suggest maybe one being scored and merging both of those would not be unreasonable. And then in terms of the other offerings, metastatic tumours, nephroblastoma, which is in the differential, but probably differentiated best on the degree of mitotic activity, and that was extremely low in this case. As I say, I couldn't find a single mitotic figure. And then I guess the main, or one of the main differentials would be with the solid variant of papillary renal cell carcinoma. But we were told this tumour was strongly WT1 positive, which would be unusual in papillary, if not very unlikely. So let's see what people think. Can we score this case? And yeah, looks like we can. So I'll let people. So we're well over the hundreds there. So metanephric adenoma, full marks 1, metastatic tumours 0, nephroblastoma 0, renal cell carcinoma papillary 0, and metanephric adenoma, adenofibroma. Oh, look at that. What do we do there, John?
Well, we give them the benefit of the doubt and give them 1. I'm not prepared. It's only a single person. I'm not prepared to have that discussion. But that is a classic. Who would have thought?
It is a classic. We have to get a screenshot of that one. What would the chances be? Right. Anyway, so we'll go for 1 then. When in doubt, be generous. Right. So that is that case. So this nice view, which I'm presuming is somewhere in Bristol that John's put, is a cue for me to stop sharing. And I will let John start sharing.
You have to bear with me. I managed to cock up. I'm not logged into the Slido. Right, here we go. So yeah, that's Bristol Docks. Let's hope it goes. Right, so your real hard work is going to start for the next 6 cases, I'm afraid. So that was just Nick always gets the easy half. So AC7 is a male, 69. We get a nephrouretectomy, and no immuno was done, and we're told that there's a diffuse circumferential thickening of the entire length of the ureter. So these are the sections. You had 4 sections of ureter. And you can see there's probably vascular invasion out here, and there's possibly tumor in here and here and here. Unfortunately, for some reason, the scan slides were rubbish. And I do apologize to that. It was picked up by some people, and you could not really focus on it, which does degrade the interpretation of the cellular detail. So there's that possible vascular invasion. And here's another section. You can see, again, there's tumor out into the level of the fat here. I'm showing it on high power. So quality of the slide, I'm surprised this wasn't higher, but maybe people were obviously using the glass slides and not the digital slides. So we are told that, yeah, suboptimal for classification, lots of LVI. Some people would do immuno to confirm urothelial type. Yeah, we're not trying to give you the heebie-jeebies. We try to ask you simple questions, which we think may have a lot of intervariable interpretation. But this was a T3A, as someone has mentioned. I'm not quite sure. Some of the graphics does get mutated across. Not quite sure how they managed to do that. And then people were talking about doing. Some people wanted to do MMR as well for the Lynch, and there's a lot of evidence was suggesting that upper tract urothelial carcinomas are associated with Lynch syndrome, but that's probably not holding out in later studies. And this is the spread of diagnoses, and clearly it's going to score because more than over 80% just recorded urothelial carcinoma. There's some poorly differentiated, nested, glandular, squamous. I'm having a bit of difficulty with microcystic again. Having a little bit of difficulty with these 2 lower ones. Someone queried prostate adenocarcinoma, and someone queried micropapillary. Oh, actually, no, that's just someone putting a differential, so we can ignore that. And then some single person wanted to call it a well-differentiated carcinoid, which would be somewhat unusual in this location and with that morphology. So, are there any comments, Nick?
There are no. Ooh, you've moved on.
Oh, we can still score it.
Okay, there aren't any comments I can see here.
Okay. And let's go to the.
Wondering whether you give people an option to potentially merge all the TCCs as one, or people are going to be a bit more stringent in terms of voting down particular variant morphologies.
Well, we'll let them decide, shall we?
Yep.
We've got enough to, anyway, we shouldn't be talking whilst people could score. And let's go on to the scoring. So you ready, Nick?
Yep.
1 for urothelial carcinoma, 1 for poorly differentiated. The nested just about get in. And half marks for glandular, half marks for squamous, nothing for microcystic, nothing for carcinoid, nothing for prostatic, and nothing for, well, micropapillary wasn't there. Oh, then we had a supplementary question. Oh, what happened there? So the supplementary question was staging. So I showed you the tumor was out into the fat, and 98.8%, that's pretty good agreement, were thinking it was T3, T2, and outliers. So I think we can score this. So I'm not going to wait for very many people to score. And then the supplementary question. Oh, sorry. Did you see that, Nick? I was going so quickly.
No,
PT2 was 0.
Yeah.
PT3 is 1. PT4 is 0.
Yep.
Okay. Now we're going to have to do a little bit more work on the next case, which is a AC8, a female of 48, bilateral ureteric obstruction. And we are told this immunopanel. So you're trying to remember this for later. We've told it's pancytokeratin, CK7, CK56, P63, GATA3, E-cadherin, CA125, and CD138 are all positive. And yet we're told that ER, PR, P16, S100, CK20, WT1, and mammoglobulin are all negative. And this is what the tumor looked like. Some fragments. And it had in areas, but not all areas, it had a linear arrangement of cells. Some with, I suppose you could say, argued some had lumina within them. In other areas, and these were very minor areas, there was a more sort of voluminous cytoplasm. Well, I suppose you could argue that some of them were clear in these ones. But this was a minor component. So some would seek further opinion, more immunohistochemistry. There was a small percentage wanting, didn't think it was suitable. So really the comments were pretty much down to this. Could it be metastatic lobular carcinoma of the breast, or could it be a primary? People were saying that they didn't see any in situ component, and that's would have helped them. CD138 positivity, but these cells don't have a plasmacytoid morphology. Again, they're talking about this. The ER negativity and P63 positivity is against this being a metastatic breast cancer. And also the fact it was in the urology EQA. I can't see a definite CIS. Not plasmacytoid enough and too cohesive in areas to be plasmacytoid variant. So people were thinking, could it be the plasmacytoid variant, or could it be lobular breast cancer? That was the sort of main differential that people were commenting on. And we got quite a long list of differentials. And this is where your work really does begin, because looking at this list, you can easily make 78% made the diagnosis of a plasmacytoid, which was the proffered diagnosis by the submitting pathologist. So we're happy that this can score. And then the problem is, how do we score all the other bits and pieces? So in the past, we have lumped quite a few of the urothelial carcinomas together, although obviously the previous case, we didn't. So you could argue that the top 3 cases would lump them together. It didn't have the CD138 is positive in any poorly differentiated urothelial carcinoma, so it's not specific for plasmacytoid. It was ER negative and P63 positive, which again would point away from breast. So the metastatic tumor is less likely. But I think the top 3, we should really merge them together, because it wasn't, the best example ever of a plasmacytoid, but it was pretty good. Clear cell carcinoma, less convincing that there were clear cell areas, but other people were thinking about it as well. Was it an adenocarcinoma signet ring cell type? Well, it didn't have mucin, extracellular mucin, which you'd expect, and there wasn't many signet rings. I know that this group sort of lumps it together, that it's a different type of mucin, and again, the mucinous is not quite right. A lymphoepithelioma, well, it didn't have a diffuse infiltrate of lymphocytes, and these two really are the same entity. We seem to have separated them out. Micropapillary, again, this has a specific morphology and didn't really resemble that. And then with glandular differentiation, it really didn't have glandular differentiation in the bits that we saw. Someone put an other and then called it just a poorly differentiated carcinoma. We weren't going to commit either way. And I think that's fair enough given the immunoprofile. And then there was some person thought it was squamous cell carcinoma, but there was no keratin expression at all that I could see to make it into that. So okay. Are there any comments?
There are a few comments.
I can imagine.
So some of the comments are actually coming in on the chat in Zoom rather than through Slido. So it's easier for us if you can type your comments into the Slido. But somebody here has made the point that I called this plasmacytoid, but had an almost identical case yesterday, which was metastatic pleomorphic lobular breast, ER negative, exclamation mark. And interestingly, pleomorphic lobular of breast, I found out a few months ago, can actually be uroplakin positive as well. That was the first non-urothelial tumour that I became aware can stain with. So that makes this distinction even more tricky. Somebody's said that E-cadherin is normally positive in plasmacytoid variant, but E-cadherin can be lost.
Variable.
I think can be lost, not always, but certainly can be lost in the plasmacytoid as well. They've put underneath the meant negative. E-cadherin can indeed be negative. So again, that doesn't really help. And as John's alluded to, there's a lot of overlap. Somebody else has made the point that this is a specialized EQA, so lumping all is not appropriate. That's in capitals as well to emphasize the point.
It's not that specialized, I hasten to add. So I don't think it was, it had some linear arrangement of the cells in a line. So that was pretty good for the sort of plasmacytoid variant. But does it make a lot of difference? It's poorly differentiated tumor as my grade. So I'll leave it to you guys to vote, but I would be generous to the top three. And the fourth one, certainly it would be within your different, I think you would probably report it out as a plasmacytoid, but exclude the possibility of a metastatic tumor. But the P63 positivity would be somewhat unusual for breast cancer. But I wouldn't necessarily say nothing is never.
And what's making this case quite difficult is because of the lack of a convincing conventional urothelial carcinoma or urothelial carcinoma in situ, which about half of the plasmacytoids will have. So that ups the reason why metastatic tumor is probably reasonable to exclude, especially in a young woman.
Can we go on, because we've got quite a lot to do? Okay, so I think this is scoreable. So I'm not going to wait for very many people to score it. And then if you could go and score it, bearing in mind our comments that we've directed you towards. Right, I'm going to score it. So plasmacytoid obviously scores 1. Urothelial carcinoma scores 1. Poorly differentiated scores 1. Metastatic scores 0.5. Clear cell carcinoma 0. Urothelial clear cell 0. Signet ring adenocarcinoma 0. Mucinous is 0. Lymphoepitheliomatous 0. Lymphoma-like is 0. Micropapillary is 0. Glandular differentiation is 0. Other, well, that's a bit tough, but that scores 0. That serves them right for using the other. And then pure is also, squamous cell carcinoma is also 0. And these are just some references talking about CD138. It really is not specific for plasmacytoid. It can stain any high-grade nasty tumor. And also we mentioned about E-cadherin, and in the 4 cases, they were all negative for E-cadherin in this series. So these slides will be available at the end if you wanted to make a note. So let's move on to the next case, AC9. Now, this is a case that has been sat waiting to be used in an EQA circulation, and I have been desperate to put it in, but Nick has been holding me back, shaking his head, saying this will never score, and he's been proved right for yet another occasion. So he's a male of 87. We're told that it was a big blood clot. He's not very fit, and it was all embedded in 3 cassettes, so not vast quantity. The CD68 highlights the giant cells. There's focal positivity for SMA, but it's negative for cytokeratins, A13, MNF116, CAM5.2, 34 beta, P63, CK7, and CK20. So through pretty much everything has been thrown at this tumor. The only thing which hadn't been thrown at it was a GATA3, and that's because this case is quite old, and GATA3 wasn't really widely available at the time. So it really has sat around this case. It's negative for CD34, S100, CD31, and the PSA is negative. Again, this is before NKX 3.1 was available, which you may have added on. And this is what it looked like. So there's pictures, there's blood clot, there's more cellular areas, and necrosis. And it shows these giant cells like this, quite odd looking. And these are the ones which were 68 positive in a background which doesn't look particularly nasty, although there are occasional unusual cells. And there was a more cellular component as well, which was highly mitotic, with ring mitoses, general nastiness. And as Nick was going to say, 66 felt it was not suitable for the EQA, 57 wanted further tissue, further immuno, and 30 wanted more blocks. And then 73 would seek a secondary opinion. So basically, it was such a lovely case that it seemed this is going to move into the educational realm straight away. So us osteoclast-rich urothelial carcinoma favoured, but would send for an external opinion. And then people would like the GATA3 and Biomentin. This is a very challenging, I don't really think suitable for inclusion in EQA. Educational, despite the absence of cytokeratins seen here, the most likely is that of sarcomatoid urothelial carcinoma with osteoclast giant cells, given the age of the patient and the absence of any previous history of surgical intervention. However, I note that several authors, so if we conclude they probably were poorly differentiated carcinoma rather repressing a true giant cell tumors. Who are thinking this? I'm weary and still 6 years to retirement. That wasn't me, his dad. And the differential diagnosis, not quite enough. We just about fitted it into a slide, but there was quite a lot. So the most popular diagnosis was urothelial carcinoma with osteoclast-like giant cells, and that is probably what it is. The problem is the terminology is extremely mixed up in this area. What is slightly more concerning is that the second most popular diagnosis was a giant cell cystitis. Especially as the patient actually died 6 months later. So, I mean, yes, it's educational. The TCC urothelial giant cell, the giant cells wouldn't be CD68 positive. So this is an osteoclast reaction like giant cells to the tumor rather than actually being tumor cells themselves. Sarcomatoid came in there. And actually, when you start splitting up, there's quite a lot of benign diagnoses lurking in the background of the malignant, which is slightly worrying. Granular cell tumor, osteocyte. Basically, there wasn't enough agreement to score. So this is not a non-scoring case. I'm not going to even bother to do that. And just coincidentally, if you're a member of ISUP, I don't want to obviously have to conflict of interest here. That is the secretary of ISUP. We do monthly cases, case of the month. And if you were looking at October 2020, there was exactly this similar case. And then there's, again, the terminology around these osteoclast-rich undifferentiated carcinoma of the urinary tract is mind-bogglingly confusing. And you can see that if you can make it into a very long term, you can always turn it into an abbreviation. So Urocut, it's a rare tumor. And again, these references will be available in the slide set, which will be available from the website. So let's move on. So AC10. Now, this is a testis which we hopefully will be able to score. So a male of 46. We are told that on slicing, there is a 20 millimeter tumor nodule, which is yellowish brown, confined to the testis. It's positive for inhibin and vimentin and negative for CK7 and plaque. I'm sure someone would have done a bigger panel than that, but that's all the panel that we are told that they did. And this is what it looks like. So it's a well circumscribed nodule with no other smaller nodules seen in the background. And the nodule itself has these pink cells with, granular cytoplasm. Rather monomorphic nuclei, but with prominent nucleoli. And we're told that it's inhibin positive. And the background testis, apart from a dirty slide, looked fine. That was the thing. The slide could have been cleaned before scanning. Oh, thanks so much for telling us the IHC for Bimentin. I would have had many sleepless nights worrying about it. And then some people did see some mitotic figures. And this is the scoring again, very high agreement, 98.6%. Some people, a couple of people may have called a differential diagnosis of malignant, but we weren't told there was metastatic disease, there was no necrosis, and it was quite small. So although there are no guaranteed things to predict malignancy in Leydig cell tumors, it didn't seem likely that it was a malignant. Sertoli cell tumors, well, they don't look quite like this. We weren't told a particularly large panel. We could have done a larger panel to pick that up. This becomes a little bit of a difficult diagnosis of sex-called gonadal stromal tumors because they're kind of like an overarching thing for all these tumors. And then the granulosa cell type didn't look very much like that. So are there any comments, Nick, on this?
No comments.
And then what do we do about these, the sex-called gonadal stromal tumors? Are we going to let them off with a half mark, or do we want to give them 0? Or because it's kind of like, it's not a good term, is it? We should have scrapped that. It was rather like, it's rather non-committal. Is that your opinion as well, Nick? Or you?
Well, it's certainly at variance from the majority when it's nearly everybody's gone for Leydig cell tumour. So maybe half, I mean, it's not incorrect, is it? But it's less correct than the majority. So I thought half would be very reasonable.
Okay, well, let's just see how tough the audience are. I'm not going to spend long scoring because people have been saying that why do we bother interested in that? Yeah, thank you very much. And we'll go on to the scoring. So you should be able to score this. Oh, why is that not? Oh, yes, it is. Right, we're already scoring. People are getting very good at this. Leydig cell tumor gets 100%, 1 point, unfortunately for them. Malignant gets 0. Sertoli gets 0. Sex cord, oh, it's moving as we speak. So is 0. Granulosa cell is 0. Did you get those, Nick? Okay, Nick.
So that was 1 for one and 0 for the rest.
That is correct.
Very good.
Right, we're nearly at the end. How are we doing for time? Oh, right, AC11, 56, male 56, laparoscopic left nephrectomy. This was provided as a scanned image only. So we put this in as a scanned image. CK7 was positive, EMA membranous, CD10 was negative, A13 positive, and PAS was positive. We're not told where the PAS was positive, but I suspect it becomes clear when we move on. And this is the tumor. Streaming with rather sort of mucinous background, would I say, leading the group like this. Another showing it sort of, again, nuclei.
Elongated tubules.
Elongated tubules. Thank you, Nick. You took the words right out of my mouth. Some wanted a bit more immuno, some wanted a further opinion, but only one felt it was not suitable for the EQA. And these are the comments. Morphology looks like mucinous tubular spindle cell carcinoma. Given the immunohistochemistry, though not specific, appears to support the diagnosis. Would probably perform CA9 and CD117. Metastatic prostate cancer, I'm not sure what they were looking at. SDHB staining to exclude SDH. Well, they tend to turn a bit pinker and with inclusions, don't they? I would highlight the mucin with an Alcium blue stain, but must be differentiated from papillary RCC, another with myxoid stroma. So the papillary RCC is the main differential diagnosis for these solid papillary RCC, because the immunopattern will be exactly the same. But having said that, there was large agreement, 93.8%, that this was a mucinous tubular spindle cell carcinoma. A clear cell papillary, I think people are obsessed with these, that we're going to put them in every circulation. And if they guess it, they eventually get it right. But unfortunately, this didn't look anything like a clear cell papillary. A chromophobe, again, didn't really resemble that. Collecting duct carcinoma collecting ducts is a high-grade nasty tumor, which is infiltrative. This is well circumscribed tumor. Unclassified, again, renal medullary carcinoma, metastatic tumors, clear cell, papillary solid. So I would just highlight that this is not too far wrong. ALK-rearrangement associated, I think that was, and the papillary type 1 and type 2. So the type 1 is someone's put a differential. So the solid variant and the papillary type 2 are within the differentials of this morphology, although were told it was PAS positive in the background, but again, that's not totally specific. So with that level of agreement, it's clearly scoreable. Are there any comments, Nick, or any comments you'd like to make?
No, we're commentless. So. Okay,
so scoreable. I'm not going to wait for long for this. So if you want to just checking that people are still alive and and out there, they haven't all decided to start watching something else. And then the scoring is open. So please score away. Okay, let's go into the scoring. So mucinous tubular and spindle cell carcinoma, that scores 1. Clear cell papillary 0. Chromophobe 0. Collecting duct 0. Unclassified 0. Medullary 0. Metastatic tumor is 0. Clear cell 0. Papillary solid. Oh, you are so tough. 0. God. 0 for ALK. Papillary type 2 is 0. I can't sell these people, can I? So just to, if you had been around as long as us, we'd actually used this case before in circulation C.
I was going to give a bonus mark if anybody spotted that.
No comments. No one would put that in the comments. That really would have been sad, wouldn't it? So obviously, it's a long time ago, probably 180 cases ago. But this has been so we reused it using a pure digital to see if it made any difference. And you'll be glad to know that not only does it make no difference really, but also our education has improved, and that this is much better recognized now. So back then in case C29, presumably the 29th case of the EQA scheme, since Nick restarted it, 71% chose it as the diagnosis. So it was only just about scoring. But interesting, the papillary renal cell carcinoma was the second differential. Okay, so I think that's all we're going to say. Let's move on to, so the other digital case was this case, which had an awful lot of immunoprovided. So a female of 58, small mass kidney biopsy, and we had 2 needle cores. Oh, sorry, I better go back because how do I go back? Oh.
I see how you've not claimed responsibility for putting this one in as well.
I can't put in every silly, stupid case. So it's a tumor, and let me just go back a bit. Sorry. I just emphasize, we're going to see the immuno, but it's CA9. We were given a CA9, you're given a CK7, a Vimentin, and a PIN cocktail, which is the P63, 34 beta racemase, and a CD10 was also provided in the scanned images. And you can see at this core, you've got normal renal parenchyma here, and you've got a nodule of tumor with some sort of cystic areas and some tubular areas, and there's smooth muscle. And some of the cysts were like this, cystic areas, and some of the nuclei were slightly pushed towards the luminal aspect. And the CD10 showed luminal staining. The CA9 was positive, but the question on everyone's lips was, is this all the way around or is it cup shaped? And I think you could say that this cell was all the way around, but these cells were cup shaped, and that's all the way around. So it was like a bit of a mixture of the two. There you are. That's definitely, you would definitely argue that that was not staining the lumen there or the lumen there. But in these areas, it seems to be staining everything. And there, you see, that's not staining the lumen. But it's a bit tricky, isn't it? Now, the PIN cocktail. So this was basically showing that it's strongly positive for 34 beta E12, negative for P63, but also negative for racemase. This is an absolutely beautiful stain to do on your clear cell papillaries, because the background kidney will stain pink for the racemase, but the clear cell papillary will stain brown. And it's just because lots of labs will now have PIN cocktail. That saves you one slide, because otherwise you have to do a racemase and a 34 beta E12. It's just one less slide to look at. And the Vimentin is strongly positive. And so is the CK7. So you've got a CK7 positive, CA9's a bit, CD10's showing some luminal staining, and the 34 beta is positive. So 40 wanted extra opinions, not suitable for EQA, more immuno. I'm not quite sure what more immuno you'd like to do, and some more further blocks. I have a differential diagnosis of clear cell renal papillary, but strong CK7 reaction, clear cell renal cell carcinoma, but CK7 is against this. So CK7 can be positive in clear cell renal cells, especially in the sort of when they're cystic again. Again, some people don't like our Vimentin, putting Vimentin, but Vimentin is really useful in renal tumors, especially if you're differentiating between chromophobe and clear cell and things like that. Someone put it as a other diagnosis of endometriosis. And then this is the comment of the day, really. Why was a PIN cocktail performed on a female patient? I think they're missing the point. Slight cup shape, CA9, lack of papillary architecture plus CD10 positive is against the diagnosis, CK7 against clear cell renal cell. And then someone's put clear cytoplasm, nuclear arranged away, hematuria and foamy macrophages also observed, fibrous capsules, hyalinosis, glomerulosclerosed, blah, 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 blah. But the most important comment, and I do thank people for putting in comments. Now, let me just get rid of this. And I've highlighted the bits in red that you can't put comments in red. That would be, capitals is one thing, but red would be something beyond. So this is really, I've left it all in as they put, and it's worthwhile reading this because this is probably, if we wanted to score this, which I think we probably can, this is the how we would score it. So they wouldn't be definitive about the classification. Clinical team need to know that it's a renal cell carcinoma, best classified on resection specimen. Tumor morphology falls into renal cell carcinoma with leiomyomatous features. That includes several entities: clear cell papillary, and the really rare ALK-mutated RCC, RCC associated with TSC and mTOR. On the basis of the immunoprofile, the literature suggests the features do not entirely fit the clear cell papillary. Although this is not excluded, a CT can be focally positive, but we only have limited material here. What does the rest of the tumor show? And the CK7 positivity and 34 beta positivity is not entirely in keeping with clear cell renal cell, especially a 34 beta. I favor this diagnosis less, but we only have a small amount of tissue, and we don't know whether it's only focal. The features fit with tumor RCC, leiomyomatous stroma, is associated with TSC or mTOR mutations. The TSC mutation in this tumor may be sporadic, although some patients may have underlying TSC. So clearly this is somebody who knows their stuff. And this is what we've got. And you look at this and you think, oh my God, we're never going to be able to score this. But if we actually go through the entities and start thinking that we need to tell the clinicians that this is a renal cell carcinoma, but we're not sure, we're rather not going to type it until we see the tumor taken out. That is the attitude we need to take. But there are some certain entities in here which we can discount as not looking anything like this. So the top one, it was actually called a clear cell papillary RCC with leiomyomatous stroma. And that is really the highest that was scored. Clear cell with leiomyomatous stroma, I think that's fair enough. The clear cell, again, I think that's fair enough. And then this is just, unfortunately, us with two diagnoses the same. And I think the renal cell carcinoma unclassified is fair enough as well. So the top 5 diagnoses merged together would be scoreable, would make the case scoreable. And then let's have a look at the ones beneath it. So the collecting duct carcinoma, this again is a high-grade tumor, nasty thing. And it doesn't look anything like this. I would suggest that that's incorrect. A mixed epithelial stromal tumor, and we do have another one further down of a cystic nephroma adult. These would have, the stroma is wrong for that. So they have the ovarian type stroma. Renal medullary carcinoma, again, this is a high-grade tumor. Renal cell carcinoma papillary, type not specified. That's rather a tricky diagnosis. The CK7 was positive. The racemase was negative. So a papillary renal cell carcinoma with racemase negative is extremely unusual. And then this is where we start to have important things. Chronic obstructive pyelonephritis, that's clearly not correct. Renal medullary interstitial cell tumor. We've had one of these before, which didn't score. That's the tumor with the amyloid in the stroma. Multilocular cystic, and they're very small. This is multilocular, well, they're normally small. Multicystic, again, of low malignant potential. And we do have the CK7 positive staining the cystic area. It's not quite right for that. You're not supposed to see solid nodules of things, but I don't think it's far off. Don't know, obviously, urothelial carcinoma. That is, I can't really think that's correct. Metastatic tumor, partly because the vimentin and the cytokeratins were both positive. That would be unusual for urothelial. Metastatic tumors, again, benign nephrosclerosis, and then this endometriosis, nephrogenic rests. And then we're on to translocation. I don't want to do that. The translocation, I think it's slightly difficult with that. Normally high grade tumors, this wasn't particularly high grade. Tuberocystic, again, I don't think that's far wrong, but it's not right. Cystic nephroma is wrong. Mucinous tubular cell maybe that's because of the previous case and someone's clicked the wrong button in the thing, but it's clearly not one of those. So I think if we take the of merging quite a few of the top ones, then we can score this case. And I think the bottom line is we need to tell the clinicians that this is a tumor, unclassified, but there are some certain entities that people put in which don't resemble this tumor. So with that, let's
John,
everyone's
score. You've convinced everybody it's scoreable. Just a comment here: clear cell papillary-like areas can be found in clear cell carcinoma. Hence, absolutely, diagnosis on true cut would be difficult. I can't tell you the next comment. This comment is so lengthy, I'm almost in a coma with boredom. The original diagnosis in AC12 doesn't exist in the literature, I think.
I think the original diagnosis, well, the diagnosis that's given by pathologists is not necessarily the correct diagnosis, if you know what I mean. The submitting diagnosis, I mean, I think it's a very confusing area of these leiomyomatous stromas things. I think people are seeing the leiomyomatous stroma more and more in tumors, and then they're trying to sort of tag it on as a separate subentity. But so hopefully the WHO will try and try and sort out these into. I don't think they're just the leiomyomatous stroma is seen in lots of tumors, so it's not particularly important, I don't think, at the moment.
People want to score it anyway. So.
Anyway, they do. Let's move on. Let's try and score this then. There were quite a lot to get through, so I'll give them a little bit longer. We've got to 100. Right, okay, so clear cell papillary is 1. Leiomyomatous stroma is 1. Clear cell is 1. Leiomyomatous stroma is 1. Unclassified is 1. Collecting duct is 0. Mest is 0. Renal bladder is 0. Papillary not specified is 0. 0. Renal bladder 0. 0. I think everything else is 0. So this is also, so this paper which has come out recently, and it talks about RCC with fibromyomatous stroma. So even the terminology has changed since we designed the drop-down boxes, which were following the 2016 WHO in the Vancouver classification, when it was all sort of rather preliminary. So there's a lot of names and things are coming out. So at this point, we're going to move over to the prostate cause. Are you there, John?
Hello. Is that sharing okay?
Yeah, looking good. It's looking good.
Right, I'm going to finish off by doing the 3 prostate cores. This first slide is one of John's that has this little creature on it. So answers on a postcard how you would taxonomically classify this for extra credit. I think it's got 6 legs, so it's probably some kind of arthropod, probably a louse of some kind. Looking at it's about the same in length as the diameter of the core. But anyway, we will move on. So first core is part of a template biopsy. PSA is relatively high at 14, looking quite solid and blue on low power. And those glands are abnormal, closely packed, not separating the fibromuscular stroma, with some pink kind of amorphous debris within the middle. There were some other areas, such as this area, where the glands down here are becoming quite a bit less well differentiated, probably poorly formed here, little clusters without much of a lumina in between. There was another, oh yes, there was the other area, so I've skipped a slide that's gone to this area down here with similar poorly formed glands. There's another poorly formed gland just at the edge of here. Other tufted hyperplastic glands here, looking very dark, possibly some nucleoli. One of the things that is a bit more difficult on scan slides is nucleoli don't sometimes project so well, but there's some other poorly differentiated glands just at the edge of that tufting of the hyperplastic glands as well. There was only a few comments on this. Some people wanted some histochemistry, some more levels, but no one thought it wasn't suitable for the EQA. The comments were mostly about Gleason scoring, that it was mostly Gleason group 3, and whether those areas that I showed you of the poorly formed glands were single cells or not, for 4 versus 5. Low percentage of pattern 4 was one of the most common comments that came out of the comments that we received in this case. Some people commented they would do immunohistochemistry as an almost routine thing on these types of cases, and that kind of tufted hyperplastic area that wasn't solid and didn't have necrosis or particular nuclear enlargement or pleomorphism, someone was suggesting could be introductory, and they would do immunohistochemistry to sort that out. And then a comment that there was just loads of cancers from high-grade PIN2, which probably sums up most things for this case. So over 98% thought it was adenocarcinoma. A scattering of people thought that area of the tufted gland could be introductal with some adenocarcinoma in it as well. That might, it's whether you feel that should be merged or given with adenocarcinoma for one, or given potentially a half, because the introductory carcinoma would potentially push the patient into a higher risk. With a little bit of Gleason pattern 4, they might be still eligible for active surveillance, for example. So that's something to consider for that one. And then adenocarcinoma with AIP, or atypical intraductal proliferation, kind of halfway between high-grade PIN and intraductal carcinoma, probably is okay to merge with adenocarcinoma, depending on how you feel. So I think we can probably score this case, but we should probably let you decide for a few seconds. So we're already at 100% with 70, 80 odd people. So that's probably enough to move on. Okay, so if we go and score it. We're just approaching 100 people, so just move on to the scoring. So adenocarcinoma given a 1, adenocarcinoma with intraductal given a 0, and adenocarcinoma with AIP looks like it's also given a 0, but marginally, which is probably a bit harsh, to be honest, but there we go, that's the scoring. And then we were asked a supplementary question, which is about the Gleason group grading. So the vast majority thought those little areas represented a little bit of Gleason pattern 4. So 82% went for Gleason 3+4, or grade group 2. We normally consider representing either side of that. So whether Gleason grade group 1 gets marks as well as Gleason grade group 3, although there was significantly less 4 than 3 within the core. And Gleason grade group 8 was the people that thought there could be a couple of single cells within that area that I showed you, warranting Gleason, I suspect, 3+5 equaling 8, so Gleason pattern 4. But over 81, nearly 82% of people thought it was grade group 2, 3+4. So that's probably scoreable as well. I'll just give you 30 seconds to. Okay, that was quick, approaching 100 with easily scoreable. So if we could score that supplementary question. And we're just approaching. Okay, we're at about 100 now, so I will have a look. Gleason grade group 1, which is group 6.
Yeah, this is the problem with letting people score these. Of course,
yes.
we're. I'm afraid due to the nature of the Gleason scoring, we can't.
Oh, you're going to say something, John?
No, sorry, it's just someone's comment was saying that are we allowed a 0.5 for the Gleason? I mean, with that agreement, I think we just grade group 1, and we have to do what we've agreed in the past, which is that I think we should review the grading and how we score them.
Yeah, I mean,
the Kappa statistics are so bad with Gleason grading that, in fact, I don't think grade group 1. The difference between that and this is basically this case bordered between 3+3 and 3+4, with like about 5% pattern 4. So they probably would be not any disservice would happen if they were called Gleason 6. But I think in this case, if you go to the next one. So everyone thought 3+4 was correct, and go to the next one. You see that was the issue with this case, that it was probably more wrong to be 4+3 than 3+3. So I think we need to refine the Gleason grading going on, but in this EQA, and then go to the next one. In this EQA, only this last group will score 0.
Yeah, I mean, we put it in like that because when we were just introducing the Gleason grading scoring and making it scoreable, wasn't it? So I think having done it for a number of circulations now, we can probably refine it and
maybe give some people half marks. Actually, because there are 2 parts to the question, they only get, it's actually half of a half.
Yeah.
So we'll take that forward and think about it a bit more. But for this,
I'm probably
this circulation,
I'm relating it to management more than anything, to be honest.
Yeah. Okay, let's move on.
Okay, John, your AI system.
Oh yes. So in the last circulation, I showed you Page's AI system. That was about 6 months ago. So this is not, you shouldn't be doing a direct comparison to your memories of the Page with this one. This is an IBEX system. So it's a bit more mature in the system. Oh, hold on a second.
Oh, sorry.
And and there is a lot of evidence out there that they've done lots of presentations, which I'm sure some people will have listened to, and marveled at the some people's screens, which are extremely large, in order to get the core biopsies in one single massive great screen. But so this is the IBEX system. They've allowed us to demonstrate it on this case. I was only given access to it at the weekend, so I've only had a brief play around with the system. So I'm sure it does a lot more than I'm going to show you, but it just shows you what the systems are available at the moment. So if you go on to the next slide and then press the play. So this system uses a heat map system. So at the moment, this is heat mapping for cancer. The redder the bits, the more the cancer, the more likelihood that there's cancer. So you can see that you can then change it to Gleason grading, and the blue is Gleason pattern 3, and the redder it gets is high grade. So you can see the areas that we've already highlighted on either end of the core were the bits which were easy, and you just tab the space bar and that removes the heat map, so you can have a look at it more carefully. And then these were the little bits at the end, which were the Gleason pattern 4. And this system is quite quite developed. You can change it to, what do I go on to next? High-grade pin. And you can see that that area next door to those glands, which we were thinking about, was high-grade pin, which I think some people wanted to call the introductal, they would call it high-grade pin. The next thing that this system can do is detect perineural invasion. And you can see it's picked up a few areas here. It's blue, so it's not particularly certain that it's perineural invasion, but if you wanted to look at it, again, let's focus on this bit here. And tabbing in and out, you can see there's a little nerve there. And if I'm going to go to higher power and show you this area here. And it's highlighting this nerve here with tumor adjacent to it. So the more important things that which we really, there was no difficulty about calling this cancer, but measuring tumors is quite boring. Measuring length of tumors and length of the core is also tedious. So this allows it, and it gives you the information in the right-hand panel. So this is the measuring the tumor, measuring the core length, and then it can generate the percentage as well. And those numbers are produced in the right-hand panel, and the Gleason grade, which it scored at 3+4, grade group 2.
Great. Okay, we should move on to penultimate case. So AC14, 59-year-old male, core biopsies. So we have received, and an immunohistochemistry with 34 beta E12 was performed, which we're given a slide of for you to have a look at. Levels on the slide, fairly long core. This was an area of interest with these paler glands. I'll show you this on higher power just to show you that this measured about 1 millimeter, so a significant area of paler glands that were different to the adjacent benign glands. On slightly higher power, they have some blue mucin within them, starting to maybe get towards some crystalloid, some nice eosinophilic nucleoli, macronucleoli in this gland here that looks quite abnormal. Some amorphous kind of eosinophilic debris as well. Glands not really respecting each other's space in that area. We were given a slide of the 34 beta E12, which highlights some glands with a complete basal cell on the right-hand side of the core as you look at it, and glands here which lack the basal cells. There's a little bit of smudging of the cytoplasm. There was a couple of comments about an occasional basal cell. I think it's actually a secretory cell showing some abnormal 34 beta E12 positivity, because you can see it's got the luminal apex up here. So I think that's actually a secretory cell, which is known to show a little bit staining with 34 beta E12 when it becomes towards malignancy. So there's a few comments about that. And on the immuno, although it was differently orientated, as a lot of people also pointed out, it was still a good millimeter or so of just under a millimeter of typical area. So 7 people thought it wouldn't be suitable for the EQA, and a smattering of other comments. Most of the comments revolved around whether there was enough of these atypical glands which did lack basal cells to call adenocarcinoma, or whether this should be ASAP, and that's a kind of where your personal cutoffs are. We personally double report these type of cases in order to try and push it towards a definite diagnosis for the patient and for these patients, because we know it's difficult. Pseudohypoplastic type carcinoma was mentioned, with those paler glands with quite a lot of cytoplasm. Small focus difficult to grade, as small focus usually are. And this comment down here kind of sums this case up. Are 12 malignant glands enough to diagnose adenocarcinoma or not? 87% of us thought there was enough to call adenocarcinoma, and as you would guess, the next favoured diagnosis would be ASAP. People were thinking there's just not quite enough to think of calling this adenocarcinoma. The reporting pathologist called it adenocarcinoma, Gleason 3+3 = 6. There was 2% of of us that offered a benign diagnosis, and this adenocarcinoma with atypical intraductal proliferation. I suspect because one of the occasional basal cells that were possibly interpreted as appearing was what created that diagnosis. So I think we're probably scoreable based on that high percentage of adenocarcinoma, but if you could just confirm that, that would be great. Okay, that was nice. And okay, we're up to over 80 people, we're up to 99%. So if you could score that case. Okay, over 100. So adenocarcinoma scoring a 1. ASAP scoring 0.5. Interesting. Benign scoring 0. And adenocarcinoma with AIP scoring 0, which I think is particularly harsh. But 71% of people thought that should score 0. Anyway, interesting. It is that people are harsher when they're at the end of a computer, as we commented right at the beginning, Nick, but there we go. Right, okay, so Gleason group grading, over 82%, 82.5% of us thought that grade group 1 was appropriate. The not applicables are those, if you add those together, were the ASAPs and the benigns, so 12.5% is not applicable. And obviously the next grade groups, 3 plus 4, some people thought there could be a little bit of 4 in there, 20 people. And going back to what we were saying about the scoring, the 4 plus 3 is probably the definite wrong Gleason grade group for this, because there probably wasn't a more 4 than 3, especially in that little focus that we saw that some people would call ASAP. So I think we can.
Well, what have you done?
I've just gone forward. We've lost a slide there, John.
Just go forward 2 then. Go another one. Go forward another one.
Nope, disappeared.
Oh, I think we removed the scoring for this case because if you go back to the go back again.
Yep.
We removed the scoring for this because we can't score this because we were expecting ASAP to score 1. It only scored a half.
Yeah.
And in the not applicable, there was someone who called it benign.
Right. Yeah.
So I don't think that's, even though there's 82%, I don't think we can score it. And that's, we're gonna have to get some complex rules around Gleason scoring these cases.
Yeah.
By moving them to grade groups, that has helped. But you could argue that if we're scoring ASAP 0.5, then the not applicables should score, but then you've got someone in the benign, So I think we decided that we can't score this. So if you go on to the next slide, we'll show the AI on this. So there were three calls again. So this is selected onto the cancer thing, and you can see the bit which is picking up was the bit which we were worried about in that call. And again, the Gleason grading was not going to go in much higher than 3. They have Gleason graded this, but unfortunately this was done before that they have Gleason it. So this is the area of interest, which we highlighted already with the blue mucin. And you can see it's pretty red, so it's suggesting that there's a high probability that this is cancer. And what the system would do you would highlight these bits, then you could go around and using the space bar, you clip in and out, and you can happy to say to yourself, well, actually, I don't think these are important, or you can marry it up with immuno. So I'm just going around the core here, showing that these are all just atrophic foci. You got a little bit excited by that single gland there, not surprisingly. But the most it's worried about was this. You can also select other things which is called a POI, so points of interest. So if you want to just go straight to the bit which it's worried about, it gives you a green blob again, which you can tap across and shows you these glands that you would probably order immuno. So it doesn't interpret the immuno yet. So even though there was immuno in this case.
Okay.
And
I think
there was a bit more.
Oh, sorry, was there, John? Sorry.
Yeah, you're gonna have to twiddle my thumbs. You got to wait until the little red thing gets all the way to the end. Oh yeah, well done. Oh yeah, that's fine. That's brilliant. And then I know that certain institutions do like. Oh, that has finished it now. So it also picks up atrophy as well. So you can select atrophy on the drop down, and it will show you atrophic areas, which could be useful for correlating with the PIRADS. But let's move on to AC15.
Okay, so AC15, PIRADS 4 lesion on MRI, and we were given probably a fragmented core, possibly 2 slightly fragmented cores. They had this type of epithelium at the end, slightly darker, bigger nuclei, some vacuolation, and some coarse brown pigment within the gland, the epithelial cells. This area here, which is tufted, hyperplastic, again, difficult to discern whether there's any definite nucleoli in some of these cells. You may be wondering if there's a couple of small ones. They could be basal cells. There could be some nucleoli in there. There is doing some kind of paradoxical differentiation as the cells move towards the middle, which is sometimes seen in high-grade PIN, where the cells becoming smaller and, in inverted commas, more differentiated than those cells towards the outside, filling the lumen in a kind of micropapillary, almost tufted fashion. So that was another kind of area of interest within this core. There was a little bit of brown pigment within these as well, which a couple of people commented on within this particular gland complex. And again, much more of this epithelium here with the brown pigment and some intranuclear vacuoles as well, which you tend to get in a bit of a pleomorphism as well, but kind of degenerate type almost. So some people wanted, most comments were really around immunohistochemistry. Only one person thought it wasn't suitable for the EQA. Focally high-grade PIN-1 core, which is that gland complex I showed you with the paradoxical differentiation towards the center, which worried some people. And then a lot of comments saying there was similar vesicle or ejaculatory duct type epithelium throughout the core. Comments describing those, no definite PIN, but considered it. Did consider introductal in that area. Perhaps it's not really cytologically atypical enough or solid enough, no necrosis, etc., but would do some immuno, noted the lipofuscin, and some people using NKX 3.1, which would be negative in seminal vesicle type epithelium. And someone got very freaked out about how much seminal vesicle type epithelium was sampled in this core. So, scoring wise, based on, it's not surprising that the benign diagnosis was most favored, followed by high-grade PIN, which I think's understandable within that gland complex, especially on the kind of scan digital slides. That was the next, and then we have a spattering of ASAP, introductal carcinoma with no invasive component, which will be a significant diagnosis to make, and some PIN A-tip. Thought there was a couple of glands that could be invasion around that abnormal complex. So 86%, 87% of us thought that this case would be benign, and that's what the original diagnosis was, noting that there was adenocarcinoma in other blocks of the case. So scoreable, and we are on the home straight. Okay. Approaching 195% of people, and 6% of people thinking it was scoreable. So if we could score it. Just get up towards 100. We're about there. So benign getting 1 mark, high-grade PIN getting 0, which I think is very harsh, personally. There we go. High-grade PNA tip getting 0, ASAP 0, and introductal with no invasive component 0. Of course, most of us thought it was benign or a non-invasive diagnosis, so not applicable for the Gleason grade group. John, your AI.
Okay, so here's the AI looking at this last core. So because the system doesn't actually find any cancer, it will just show you the three areas, or the areas that it's most concerned about, and then you can click on it and it superbly reconstructs it into the core. And these are the green blobs, the points of interest. So you can then go to the high-grade pin selector, and let's see what it picked up on the high-grade pin. What it did pick up, those glands which we demonstrated. And what's interesting is that we took the photographs of these cores before we did the AI, and these are the bits which we were concerned about, which was pin. So it's not saying it is pin, it's just saying, have a look at this, it might be pin. Okay. But you clearly felt that it wasn't. Going on, we can also look at other things. So I think this is the one which is going to show you atrophy. So you can select atrophy, and it shows you, highlights areas of atrophy, which may explain some of the radiological features. I mean, I don't personally believe that reporting atrophy, I think that gets the urologist and the radiologist off the hook, but some people do like to report atrophy as an explanation for abnormal PIRADS. And then that's that.
Great.
So it's with great pleasure I'd like to introduce Lisa Browning from John Radcliffe, who has agreed to talk to us about the educational cases. They weren't all from her, so as a result, go kind on her. So you can still ask questions through Slido. We won't be monitoring the Q&A or the chat function, and there will be no voting, so you can relax a little bit and we can relax and just listen to Lisa telling us all about this. So thanks again, Lisa, for going through these cases. Over to you.
Oh, thank you, John. Thank you ever so much for inviting me. It's very kind. Can you hear me properly? I've just put my headphones on because there's a bit of noise.
Yeah, it's perfect.
Yep. Oh, that's good. Okay. So as you said, John, these are the educational cases. So none of these have been scored, but you've kindly provided me with some of the comments that people have put in. So we can go through those very, very quickly. And there are 5 cases to get through. So we'll start with the first one. So this is, actually, before we start with the first one, what I was going to say is that the references that I wanted to give you for this talk, because already we've mentioned this afternoon when Nick was talking about the papillary renal cell carcinoma, was the fact that there's been a GUPS update on renal cell tumours in advance of the next WHO book. And in case these reference papers are useful to either any of you really, we've got the new developments in existing WHO entities, and then also some of the review of the novel and emerging and provisional renal entities. And these 2 papers are really very nice, and I'll refer back to them as we go through the talk. And the other one I wanted to refer you to, just so you've got this reference, is just, if you're interested, the report on the use of molecular diagnostics in kidney cancer, because that might be useful to some of you, and this is a good paper. So case A16. So you were told for this case it was a man of 58 and his kidney was replaced by a very large tumour. So this is an 18-centimetre renal tumour, which macroscopically was composed of large cysts with smaller solid areas, with a solid 90mm nodule in one area and a bubble wrap type cut surface, which may or may not be a clue. And then we've got some photographs of the slides that you've seen. This is a nice low power view. We've got background kidney over here. We've got this area which looks papillary of sorts, and we'll come back to that in a moment and have a look at that at higher power. We've got this area here which looks more solid, a cystic component as was described macroscopically, and then over down here I'll show you that because I think that's a nice area to draw your attention to in just a moment. But even at low power you can see that morphologically this tumour is variable, and I think that's a really important feature to see. So going up to the bit that looked papillary, we've got these hyalinized cores here, and these papillary structures are lined by kind of low cuboidal type cells here, and other areas that look papillary have got multi-layering here and almost a cribriform type appearance. And going over to the other area over here, which looks more solid again, you've got this cribriform type appearance, which in some areas is almost reminiscent of an acquired cystic disease associated RCC. And this is a higher power view of this area, again showing these solid areas and cribriform and almost sieve-like arrangement of the tumour cells. And as I said, I drew your attention down to the bottom left of the slide, and this is an area that looks more tubular, so tubular cystic type appearance, lined by a single layer of cells. And if you look in this area, this is where I think more characteristically you're seeing morphological features which are described in these tumours. And this is quite nice. I was trying to find some of these that people would say are very textbook-like, but here you go, a CMV-like intranuclear inclusion here, or prominent nucleolus that you're seeing here. So I think I've given you all the clues, but what I wanted you to see was that it's very variable in its morphology. And then the immunoprofile, it's Paxate positive, as you'd expect to see in a renal cell carcinoma. It's positive for cytokeratins, vimentin, positive for racemase, but negative for these things here, including CK7. And then the big diagnostic clue here is fumarate hydratase negativity, which is abnormal. So this is a fumarate hydratase deficient renal cell carcinoma. These were the comments, so thank you, John, for providing those to me. Some people asking for further opinion, immunohistochemistry, further blocks, and then the selected comments. People have come up with a diagnosis of FH-deficient RCC and also mentioned the fact that that's not in the drop-down menu, and John and I have discussed that quickly already. Someone has said metastatic prostate cancer, I can see with the big nucleoli that you might have thought of that. SDH deficient, possibly another metastasis, and then somebody here has talked about tubular cystic high-grade cancer with fumarate hydratase deficiency as well, and I'll come back to that comment in just a moment. But again, those of you who, this is a percentage of those of you who actually, not everyone submitted an answer basically, so about 60% of people submitted an answer for this case, and of those approximately half have said that it's an HLRCC, and I'll come back to that again in a moment. In comparison with the submission diagnosis of FH-deficient RCC, and the majority of the rest of those who've actually submitted an answer have suggested this is a papillary type RCC. So these tumours are rare, they are really very rare, so not many people are going to see one at all during their working practice, but they're really important to recognise, and they're important to recognise because these are incredibly aggressive, and patients often present with metastatic disease, and they, a 16-month follow-up, almost 50% of the patients will be dead from disease. And they're rare, and they're also important to recognise because although rare sporadic forms of these tumours actually are recognised now to exist, most patients that have this diagnosis are going to have an underlying germline mutation in FH, and this presentation with the renal tumour might be the first time that this diagnosis is picked up. So although they can also have the associated cutaneous and uterine leiomyomas, it might be that the renal cell carcinoma is a lesion that they present with. And as I said, what's important in terms of the morphology for us to recognise as pathologists is that although they often are described as having a papillary architecture, and that's seen at least in areas, it doesn't have to be the dominant kind of architectural pattern, and they do have a very varied morphological appearance. And certainly I've only seen a couple of these cases, but the varying morphology is quite a key feature. And again, in the literature, they talk about the eosinophilic viral-like inclusions, these macronucleoli, which are seen in the majority of cases, but they can be really focal, I think, as we saw in that slide, and you have to really hunt around. And they're also not specific. You can see those features in other high-grade renal cell carcinomas, but these are all clues to the diagnosis and might make you think about it. So this was a nice paper for those who are interested. This is just from last year, actually. This is a nice series of 32 patients who have a proven diagnosis of FH-deficient RCC, and they just, again, have looked at the differing morphologies and clinical features among that patient group. And again, I've just commented on the variable morphology that you can see, and we could see most of that in this particular case. So the papillary areas, solid, cribriform, sieve-like areas, and the tubular cystic areas. And that was something I think we've raised before in previous EQAs, is that a differential diagnosis for a tumour that looks like a tubulocystic renal cell carcinoma, you should consider whether or not that is actually a version of an FH-deficient RCC. So if you've got a case that you think, oh, is this a tubulocystic renal cell carcinoma, you should consider testing it also for FH on immunohistochemistry. So that's an important take-home message. And at the bottom here, they've also documented a really small number of these cases that show low-grade oncocytic features. And I think these seem quite scary. This has been picked up in a couple of recent papers, and these low-grade kind of oncocytic appearing tumours were first described a couple of years ago, but more recently, actually just last month, by Professor Amin. He's published a series looking at these tumours that can be a real diagnostic catch, I think. This is one that we've seen very, very recently, showing you just exactly these features. It's an oncocytic tumour. It doesn't really look like an oncocytoma. It doesn't really look like a chromophobe RCC or any of the other more commonly common tumours associated with kind of oncocytic or eosinophilic features. But what it's showing, if you look around, is actually some intracytoplasmic vacuoles that almost look like a SDH-deficient RCC. So this, you'd look at it and you wouldn't think necessarily it was a chromophobe or an oncocytoma, but you might consider an SDH-deficient RCC among your differentials. And then this was what we came up with on immunohistochemistry here. So this was entirely FH deficient, but doesn't look like the typical high-grade morphology tumours that we're used to reading about in the literature. And what's important about the FH immuno is that you've got positivity in the background renal tubules and in the background endothelial cells and inflammatory cells here. So you have to see that positive internal control in the background cells, as well as the negativity within the tumour, to be certain that this has worked. So the immunoprofile, other than the FH, is not specific, but they're Paxate positives. They're usually CK7 negative. So going back to whether you're thinking about a diagnosis of a high-grade papillary renal cell carcinoma, often those will be racemase positive and cytokeratin 7 positive. They can be variably cytokeratin positive though, but these tumours are typically negative. So the FH deficient RCCs are typically negative. And other differential diagnoses that you might consider are really going to be dependent upon the morphology. So I can't really go through all of them, but this was again from that paper, the immunoprofile that you might consider looking for if your differential diagnosis is either collecting duct carcinoma or urothelial carcinoma, for example. And again, just mentioning again those low-grade oncocytic tumours, they recommend considering inclusion of FH and SDH immunohistochemistry with c-KIT and CK7 if you've got a very unusual looking low-grade oncocytic tumour that you can't otherwise classify. So it's just expanding your diagnostic panel for those particular cases. So we said it's negative typically for fumarate hydratase, and these tumours can also be positive for 2-succinate cysteine immunohistochemistry, but this is not widely available. FH immunohistochemistry is more commonly available, but this is also worth noting in the molecular paper I said earlier on, referred you to, that only about 80 to 90% of these FH deficient tumours will actually show negative staining on immunohistochemistry. So the take-home message from that is that even if you've done the immuno and it's positive, if you're still thinking on morphology and clinical history that it could be an FH deficient RCC, then you would suggest to the clinicians that they might consider referring the patient for germline testing. And this is just another example. This is a far more typical example that you'd expect to see from the literature, at least, showing a nice papillary structure with these high-grade cells with their big prominent CMV-like nuclear inclusions that's fumarate hydratase deficient. And as I said, a diagnosis of FH deficient RCC should prompt germline testing. Most of them are associated with germline mutation, but some can be sporadic, and that's more recently been recognised, but that's fewer of the cases actually turn out to be sporadic. If they do have a germline mutation, then they are referred to as having an HLRCC associated RCC. So that goes back to one of the comments that was put forward in the EQA. And one of the other take-home messages that even without the germline mutation, it doesn't seem to matter whether they have the germline mutation or not. The prognosis of the tumour is poor, except for these low-grade tumours, which appear to have a better prognosis, although I would caution, as these are limited in terms of how many have actually been studied. So I think I don't need to say anything else about the FH deficient RCC, and I've spent more time on that one just because I think that's quite an important case to consider. So this is case A17. This was a female of 84. We had a left renal mass on surveillance, but that actually kept growing, and what was described was an exophytic 45mm tumour with hemorrhage, which was a very circumscribed tumour confined to the kidney, and you were provided with these immunohistochemical stains. This is a really nice case, actually. So at low power, you've got background kidney, a very nicely circumscribed tumour here, and you can see it's circumscribed, it's not infiltrating out into the fat. And even at this power, but probably better at this power as well, you can see that we don't have a capsule here. So it's well circumscribed, but it's not encapsulated, which is a quite typical feature. We've got a central area of hemorrhage, although often rather than hemorrhage, you see a lot of edema. And then around the periphery here, you've got a very solid looking, another pink tumour, another one of these eosinophilic type tumours. And at higher power here, again, as I say, it's an eosinophilic type tumour. It looks quite solid from here, but there's a very sharp demarcation to a looser type area, which we'll come back to over here, which is very hemorrhagic, but I'll show you another focus. And at higher power still, the solid areas, it's composed of these closely compacted nests of very eosinophilic, almost oncocytic cells. But when you start looking around, we've got some very subtle perinuclear halos that you can see. So in some ways, this area here looks a little bit like an eosinophilic type chromophobe renal cell carcinoma. And then, as I said, a nice sharp demarcation to this other type of area here, where you'd see these typical kind of pulled out strands of cells, almost fibroblast-like, tissue culture-like cells here. And this is quite a typical feature that I don't think we really see in any other types of renal tumours. And it's been a feature that I've certainly seen in all of the ones that we've seen on our desks so far, which is not very many. And this was the immuno that you had. So you had c-Kit picking up nicely those mast cells, but c-Kit was entirely negative in the tumour cells, and the tumour cells are negative for Vimentin and CK20, but diffusely positive for CK7. This negative area here is just the area of hemorrhage. So all of these tumour cells are CK7 positive. So this is a typical diagnostic immunohistochemical profile of this tumour. And this is a low-grade oncocytic tumour, or a LOT. So these are the comments. So again, similar to the last case, someone has said, oncocytic neoplasm of low malignant potential not further classified and given the immunohistochemical profile. They've talked about the morphology being typical for oncocytoma, but immunofavoring chromophobe, because that's correct. As you wouldn't expect an oncocytoma to be as diffusely CK7 positive as that, but similarly, oncocytoma and chromophobe should both be c-Kit positive. Someone's talked about a neuroendocrine tumour as well, and someone else here has mentioned low-grade oncocytic tumour. And of those of you who submitted a response, again, it was about half of you, and half of those who submitted a response said low-grade oncocytic tumour, and the other half said chromophobe, and a few said oncocytoma. So all within the same ballpark. So as I said, low-grade oncocytic tumour, it's not in the current WHO classification, but is described in those GUPS papers that I have mentioned to you as a provisional entity. And previously, it's kind of fallen out of the group of difficult to classify eosinophilic tumours, or it would have been previously thought of as being an eosinophilic chromophobe RCC or diagnosed as an oncocytoma or oncocytic tumour. Although it doesn't fulfill the criteria really for either chromophobe or oncocytoma on the basis of the morphology and the immunoprofile. So as yet, these tumours are still quite rare. Only a few studies have been published describing these tumours, but they do have a consistent morphology and immunoprofile, and to date they seem to have an indolent behaviour, hence the term tumour rather than carcinoma. Typically, they are single tumours with a small tan cut surface looking a bit like an oncocytoma, with a solid appearance with nests of eosinophilic cells, but these cells are low grade and bland and have all the other features that I described to you earlier, including this kind of very pulled out central area into the edematous stroma where the cells look more tissue culture like. And I've already discussed a little bit about the immunohistochemical profile, typically c-Kit negative, as opposed to a chromophobe RCC or an oncocytoma, and diffusely CK7 positive, which again would be completely out of keeping with an oncocytoma. And although it could be in keeping with a chromophobe RCC, the c-Kit negativity doesn't really fit with that diagnosis either. And the rest of the immunoprofile is here. And SDH and FH would be expected to be retained. So as I said, that's your differential diagnosis. We've discussed that already, and also SDH-deficient RCC falls into your differential for difficult to classify eosinophilic tumours. And as I said, morphology and the immunoprofile are key. And again, just referring you back to that paper, they've given a very nice table at the start, which includes things like the low-grade oncocytic tumour and some of the other tumours we're going to go through, EVT, and the ALK-rearrangement RCC, not to give the game away, but you're going to find out in a minute anyway. Okay, so case 18. This is a man of 56. This was a partial nephrectomy specimen, and you are told that the tumour was positive for CK7, for racemase, for GATA3, and for PAX8. And GATA3 positivity is quite unusual in an RCC, and negative for these markers here, so CA9, TTF1, and CD10. And you've been provided with the H&E and also with the GATA3 immunostain. So this again was a really nice case. So this is a slice from a partial nephrectomy specimen. You've got a very well circumscribed tumour here, which is almost sitting within a cystic space, which is said to be a fairly common feature of these tumours, though they not always have this kind of cystic morphology. But again, it's looking very pink from this power. At higher power, you're seeing that this has a papillary type architecture. But again, it's very pink, and at higher power, you're seeing that these are very delicate looking papillary cores with a very fibrous or fibrovascular stroma, but no foamy macrophages. We're not seeing anything like that there. And if you're looking at higher power, it's very, very monotonous. And the cells that you're seeing lining the papillary structures have a almost oncocytic appearance, and very characteristic and a diagnostic feature of this tumor is that the nuclei are pushed here away from the basement membrane. So you've got a reverse polarity. So again, a papillary tumour, sometimes they can be tubulopapillary, but they are predominantly papillary tumours with these delicate fibrovascular cores, oncocytic type cells lining them that are pushed away from the basement membrane. As I say, it all looks pretty much the same. You shouldn't see necrosis, and you shouldn't see somomatous calcification either. And then this is again a very characteristic feature of these tumours. This is GATA3. So GATA3 is strongly positive, and again highlights quite nicely the reverse polarity of the nuclei here. So this is a papillary renal neoplasm with reverse polarity, and it was previously referred to in the literature and in other series that they've termed it as an oncocytic low-grade papillary RCC or a papillary RCC type 4. So I think the literature is a little bit confusing, but this is the current terminology for a tumour with this morphological appearance and with this immunohistochemical profile. So these were the comments again: seek further opinion or extra immuno. But people have actually come forward with the diagnosis as I've just given. So papillary RCC with reverse polarity, and again here, and then a very nice description at the bottom here saying they should be called an Al-Abaidi tumour, as they were first described by Cahill Al-Abaidi at the Department of Pathology in Indiana or Indianapolis in the USA. So again, I'll show you the reference for that paper, but that seems to be correct. So from those who submitted answers, that we didn't have the entirely correct terminology within the drop-down menu, but oncocytic papillary RCC I think is entirely in keeping here, or otherwise people have called it papillary, not specified, or type 1, or variations upon a theme, and then a spread of other diagnoses down here too. But this, as I said, is papillary renal neoplasm with reverse polarity. So again, this is mentioned within that recent GUPS paper, within the paper on new developments. So it's actually included within the papillary RCC classification. So if you go to that paper, as Nick was talking about earlier, they're recommending that we no longer split papillary RCC into type 1 and type 2 because there's poor intra-observer reproducibility, that sometimes the tumours show features that would previously have thought to be type 1 or type 2 in the same tumour, and also that type 2 pattern papillary RCC could now fall into newer recognised diagnoses, including things like the FH-deficient RCC and the MIT family translocation RCC. So they might not necessarily fit with just a papillary RCC diagnosis anymore. But these papillary renal neoplasms with reverse polarity are not a specific subtype of papillary RCC at the moment. They are just a recognised morphological pattern. So they're listed in there, and it's a nice paper to go and have a look at if you have one of these tumours. So these are small, they're often cystic, as I've said. We've already described them, very nice low-grade nuclei with this very characteristic luminal linear arrangement of the nuclei, positive characteristically for GATA3 and CK7. And as opposed again to a standard papillary RCC, they are negative for vimentin, or at least weakly positive, and similarly for racemase. And a standard papillary RCC you'd expect to show racemase and vimentin positivity. And characteristic as well of these tumours is that most of them are harbouring a KRAS mutation, which is otherwise unusual in renal cell carcinomas. So these are thought to be a possibly unique type of tumour, a new type of tumour that's been recognised, currently regarded within the spectrum of papillary RCC, as I've said, and so far the series to date suggests favourable outcome. So if you're interested, that's the original paper, as someone mentioned, by Al-Abadi, and then this is a nice, very recent, in the last couple of months, paper from the American Journal of Surgical Pathology with a review of all 100 cases that have been published in the literature. So those are some references. I thought that was quite a nice case. And again, if you're wanting to update yourself at all, this is about why papillary RCCs might be changing in terms of the way we think about them. And then this was a nice paper that I found about the new WHO classification and what the clinician needs to know, because I think things are beginning to get a little bit confusing. So I thought this was quite nice. This is from Professor Moch out in Zurich. So this is a really nice paper to refer to. So case A19, we're on the home stretch, I think now, and we've got 2 left. And so again, it's a nice one. This is a female of 18. This was said to be a 75mm tumour in the kidney, which was protruding into the renal pelvis. So this at low power shows that very nicely. So you've got the renal pelvis here, and then this tumour, which is almost polypoid, pushing out into the renal pelvis, but otherwise it looks fairly circumscribed. And this is a very odd appearing tumour, and I'm struggling a little bit to give you the differing morphologies, so I'll show you different areas. So we've got some hyalinized type stroma here, we've got normal background urothelium, we've got quite a lot of hemorrhage and vasculature, but we're not seeing typical papillary structures or nested areas. We're seeing kind of loose cells scattered around, but not with any real typical type architecture. But they've got really variable cytological features, some really high grade looking nuclei over here, lots with big vacuoles sitting within them, and really nothing like any other type of renal tumour that we would normally expect to see. So as I say, some cells with really high grade type morphology, quite a lot of inflammation dotted about, and then lots of these cells with these intracytoplasmic vacuoles. And yeah, I think that was pretty typical of the areas that you could see in that slide. So as I say, it doesn't really look like any other renal tumour or RCC that we have talked about or that you typically see. So I think for me, that was a clue. Think about something else. And again, here you've got the immunoprofile for the case. It's Paxate positive. It's positive for cytokeratins and vimentin as well here, focally for CK7. And then I won't go through or read out everything here. It's negative for melanocytic markers and for TFE3 and for OCT3/4 and WT1 if you're thinking along something unusual. But you were told the key immuno here, which was this one, which is ALK1. So this shows really nice, strong membranous and cytoplasmic positivity. So this is an abnormal finding. So this is a significant finding to see the ALK positivity here, and it's a defining feature of this tumour. So I think we've given the game away, and this is an ALK-rearranged RCC. So these are incredibly rare. So you've seen one now in the EQA, but actually I think there's less than 40 cases that have been published so far to date. So it's nice to have that example. These were the comments, and then a really nice description here talking about the mucin containing cells. Some of them did look like they contained mucin, the eosinophilic cytoplasm, variable kind of morphology that we were seeing, virtually no mitosis. So I think that's right. It looked very, very high grade, but there was no necrosis, there were no mitotic figures. And then going along here about the fact that it's consistent with an ALK-rearranged RCC. There's a comment at the bottom about INI1 being lost in these tumours. I'm just wondering whether this person was considering a renal medullary type carcinoma as the diagnosis, because INI1 should be retained in an ALK1 rearranged RCC. So these were the diagnoses that were given, and of those of you who submitted a diagnosis, almost everybody suggested it was either ALK rearranged, and then the rest were mostly going to be unclassified. So as I said, these are rare. They've been described for almost the last 10 years, but they really are rare, with less than 40 cases described to date. They were present within the last WHO book, given the fact they were described before that. And in the current paper, their GUPS paper, they are still considered a novel entity. So they are characterized by a rearrangement of chromosomes, which results in ALK fusion with various different partner genes. And you will be able to detect that ALK rearrangement on immunohistochemistry, as you've seen here, or molecularly using FISH, but the FISH won't tell you what the gene fusion partner actually is. So the FISH will just show you the fact that there's an ALK rearrangement. And although this is a molecularly defined tumour, as opposed to the FH-deficient RCC that we talked about earlier, this is currently not considered to be associated with any underlying syndrome. So it's defined by the underlying molecular abnormality, but it's not associated with a syndrome. So these are solitary tumours, solid or cystic, and well circumscribed and seen across a very wide range of ages of patients. They're also seen in some paediatric patients with sickle cell trait, and at the moment they're considered to be indolent, but some have been associated with metastatic disease and death. So it seems like the behaviour is also quite variable. And again, very variable morphology is quite typical of the book descriptions of these tumours at the moment, but characterised by the ALK positivity, and the rest of the immunoprofile is also varied. So I think the take-home message of this is the fact that this didn't really look like any other renal tumour, and the immunoprofile didn't really point you towards any other type of renal tumour. And when you're looking at a tumour and considering classing it as being an RCC unclassified, consider adding in the ALK1 immunohistochemistry before you sign it out as unclassified, because you might find that this is what it is. As I said, the differential diagnosis really is going to be wide and dependent upon that morphology, and consider the diagnosis in any RCC unclassified. So I don't think I need to say anything else about that. I'm just watching the time, John, so that we can finish in time for the AGM. And just before we move on to the last case, this is another paper which is freely accessible, which is a nice reference for anyone who's interested in these cases that we're going through today. And again, with a very nice, useful table. And going on, therefore, to the very last case, A20. So this was a female of 43. This was a partial nephrectomy specimen, and this was said to be a 23mm, very well-defined tumour. And this was the case that you had here. So again, you can see it's partial nephrectomy. We've got an inked surface here and a nice circumscribed, another one of these very eosinophilic or pink tumours. So we're going down the differential diagnosis for this type of lesion, which I think is the theme of these educational cases. And at low power, we can see possibly a very prominent vessel sitting out in the periphery here, and a couple of entrapped tubules. It's very solid looking, and that's conferred by a nested kind of tubular architecture here. And looking at higher power, they look a little bit chromophobe-like with these perinuclear halos. But if you look around, they are quite variable in terms of their cytology. Some of them look much more high grade than others if you start looking around. And then you've got these real monster cells here with these very prominent looking intracytoplasmic vacuoles, and they really are far more unusual looking than you'd expect to see. That's not a typical appearance of a chromophobe renal cell carcinoma, and certainly not one of an oncocytoma. And again, very variable in terms of its morphology, and again with these really big monster type cells here with a really nasty kind of atypical mitosis. So this, if you looked around, you could see these features quite easily in this particular section. And then you were given the immunoprofile here, so Paxate positive. It's positive for c-KIT, as you would expect or we normally associate with in a chromophobe RCC or in an oncocytoma. We've got scattered CK7 positive cells, but the other characteristic feature here is the cathepsin K positivity. So although you've got positivity for the c-KIT, I think on morphological grounds you would not really expect to call that an oncocytoma. I think the features are too high grade, and with those intracytoplasmic vacuoles and the general morphology, it doesn't really look like an oncocytoma, and it doesn't really look like a chromophobe RCC, and the immunoprofile is not quite in keeping with either of those. And then you've got this positivity for cathepsin K, which is quite typical in the descriptions for these in the literature. And this one had FH and SDH staining as well done for completeness, and this showed normal pattern of staining. And because it was a tumour that didn't really look like anything common, there was some molecular studies done, but there were no chromosomal losses or gains, thinking about a chromophobe RCC, and no evidence of a TFEB rearrangement either. So this was in the end called an eosinophilic vacuolated tumour, which was in the literature previous high-grade oncocytic tumour. So this is the new term for this, although these are obviously very recently described tumours. And again, these are the comments from those that John has kindly passed on to me. And someone has just said it's a high-grade oncocytic renal tumour. And the other comment I've been given here is, as we were discussing, the immunoprofile mimics that of an oncocytoma, although the high-grade morphology with the enlarged nucleoli and the vacuoles are not encountered in classical oncocytoma. And it talks about the possibility of this representing a hybrid tumour as well. And that was the list of diagnoses that were offered. So of those who submitted an answer, actually the majority, or about 50%, suggested it could be an oncocytoma, but the rest was going down the lines of it being a high-grade oncocytic tumour or unclassified, with a few considering a translocation RCC or a chromophobe RCC. So I think people are in the correct ballpark here. And these were recently described as an emerging entity, but they do have a very unique morphology and a consistent immunoprofile, which, if you see those together, will allow you to make the diagnosis with these distinct molecular genetic features. And they again have fallen out of the group of previously unclassified eosinophilic tumours, so alongside things like the low-grade oncocytic tumour that we've already discussed as well. And again, as with these other tumours, to date, there's no aggressive cases that have been reported, although we are dealing with a very short follow-up period. So I would always be very cautious about advising the clinicians to that extent. There's no real kind of male-female predilection, a broad age range. And again, as I said, most of them appear to be quite indolent and of low stage. Macroscopically, again, they mimic a chromophobe RCC or an oncocytoma. And I think we've already described the microscopic features when we were looking at the case. So solid nestic, tubular cystic, these thick-walled vessels and tubules at the periphery, and lots of these eosinophilic cells with high-grade nuclear features and the intracytoplasmic vacuoles. And we've considered the differential diagnosis already. And the immunoprofile we've also been through. So in terms of the genetic rearrangements, the characteristic features that have been reported at the moment is that they have mutations in tuberous sclerosis genes 1 or 2, but they are not necessarily associated with tuberous sclerosis. And I think that's probably all I wanted to say, John, to be honest. I had one more slide, if that's okay, unless there's any questions. And it was just really as a kind of an information slide for people. Are there any questions before I do that one?
We have got a few questions, but I really think we're running out of time. So one question was, where is FH-IHC available? Clearly in Oxford, but
I'm sure other people have got it as well, but I'm not sure where.
we're just working it up actually as we are conscious that we're sending a lot of cases to you at the moment. So the question is EVT similar to ESC? I think ESC is going to be your cytokeratin 20, isn't it? Positive.
Yes, the eosinophilic solid and cystic RCC. So then morphologically, they should have the solid and cystic areas, and then you would expect it to have CK7 and CK20 positivity. But you're right in that a lot of those have the tuberous sclerosis mutations associated with them. It seems to be that there's a lot of descriptions of tumours at the moment that have a tuberous sclerosis gene mutation, not necessarily associated with the syndrome, but that seems to be that is falling out of the woodwork with a lot of these eosinophilic tumours at the moment.
Thank you very much, Lisa, for presenting these. And you may, the audience may understand that we now have a complete collection in the EQA of all the different entities over the years. So I've done a table which I'll put into the notes of on the EQA website, EQA Lite. So every single entity that we've had in the EQA is now has an example with clicks, links to the slide on the Leeds website, so you can see all the entities and the immunopanel that goes with it. So it's a very useful thing to have stuck on your wall or whatever. So thank you very much, Lisa, for presenting those.
Thank you, John, for putting that resource together, because actually it's fantastic. It's a really handy thing. So that would be nice to share. Thank you.
I'm going to stop you.
Is that okay? I'm going to leave that in there. It's just if people want to know about what genetic tests or molecular tests are actually available, this is just a snippet from the National Genomic Test Directory that people can refer to. And this is what your local centre should be able to offer, or not all the tests are up and running, but it's certainly a bigger panel than was available a few years ago. So absolutely, that's just an information thing. Can I stop sharing?
Yeah, I'm going to bump you off. Excellent. So just concluding this session on the EQ, I just wanted to let everyone know what we're doing. So the digital format. So the next circulation AD will be 50% digital, and then AE will be 100% digital, so that will be in the autumn. That means we'll have a shorter circulation for that, so we'll probably start circulation AD a little bit later, maybe in February. Then we'll, when that happens, there's 2 levels of membership fees in the EQA. There's a lead and there's a colleague, and we'll probably just equalize those to a similar amount, just to aid or make it slightly bit easier. The digital images, we did have an outage of the Leeds website, which was very inconvenient as the circulation was due to finish in the following week. We did extend it a bit longer. And certainly I found that when I was trying to capture, the Leeds site was slightly slower. So we may look to host it on another site or parallel to Leeds in the future. The other thing which we're going to change is the organizer's time. So at the moment, Nick and myself and John claim no fees from the EQA scheme for our time, although we do claim expenses. But we think that the future we'll need to put a PA against the organizer's time, which isn't really in line to the other schemes. As to future meetings, clearly this has been a bit of a mammoth session, and but we're conscious that running 2 circulations in one meeting has also been quite a mammoth undertaking. So I think future we may go to 1 virtual and then a physical meeting combining with a BAUP meeting in the November-ish period. So that's the plans for the future. Let me see, why is this not going ahead? But the acknowledgements, really, I have to thank the people who submitted educational slides, especially Sean Williamson, who actually posted his from the States because the scanned image for some reason didn't work on the Leeds system. KPMD and the Leeds support that we get, our EQA secretary, and also the team at IBEX, who allowed us to show you the AI. So I think that at that point we're going to move on to the AGM in the
excellent. Lovely. John, thank you very much. So yes, do we have the first slide for the agenda? So good afternoon, everyone. Welcome to the BAUP AGM. And for the apologies, we have from Dr. David Griffiths, who isn't back in the country quite yet, but he has sent his finance report, which I shall present in a minute. And then the minutes of the last meeting. Do we have any actions that are outstanding? All of these minutes are actually available on the BAUP website. I don't think we will have a slide summarizing them to share with the membership today, do we, John?
I'm afraid not. I've been inefficient in that way, but I'm sure we're covering exactly the same ways, same things as last year.
Absolutely.
So I got no feedback from anybody.
Okay, so well, if we could find 1 proposer and 1 seconder to accept the minutes as being accepted.
I think we can't really do that in the.
We can't really do that. All right. Well, it'll have to be.
Well,
you
we
and
can
me
do.
Then.
No. Well, I'm sure Nick and Lisa will confirm the minutes as correct.
Yep, that's fine.
Correct.
Lovely. Thank you very much. Next slide, please. Then. So really, I would like to take this opportunity to thank Dr. Murali Varma for his outstanding, inspirational and energetic leadership of BAUP as the immediate past chairman, but also for, leading on all the courses, authorship of key articles for the college, clinical guidelines, and for his pragmatic approach, which I'm sure all practicing pathologists have found very, very useful and helpful. And of course, his is a very hard act to follow. And there is a token of appreciation on behalf of the membership that will be delivered to him in person. But this is the watercolor painting that you see here, which has actually been painted by one of Murali and David's colleagues, former colleagues at the University of Wales Hospital in Cardiff. And this is the Cardiff City Hall. And this will hopefully sit very well next to a similar painting that Murali has at home or in his office, I can't remember, of the Belfast City Hall. And these are the 2 cities in which he has spent a large part of his professional career. So a huge thanks, Murli, for your excellent stewardship over the years, and long may it continue. Also, big thanks to the EQA team today. As you've seen, they've done an absolutely sterling job. Thank you, John, Nick, John, and Lisa for the educational cases, a veritable feast, with kidneys obviously being high on the menu today, as it were. And so we will hear about some of the activities planned for next year, and also a summary of those that were held last year from Lisa, our Education Secretary. I would just also like to take the opportunity to announce that we do have a vacancy for a membership secretary. And also we would love to hear back from all of you as to what you would like from BAUP, and also what you would like to offer to BAUP. And so, please feel free to email me with any thoughts and comments and suggestions. So that's all I have to say. And then if we move on perhaps to the next item on the agenda, which is a financial report submitted by Dr. Griffiths. I'm not going to read the whole slide out to you, but you can see all the numbers and figures there on the screen to indicate that we are in a financially viable and healthy state. Obviously, we're not a for-profit society or association. We like to keep our accounts in order to present to the Charity Commission, but which is also publicly available, but also to use it to fund meetings and speaker expenses. So if you have any questions about this, all of this information is publicly available, and you can feel free to ask any questions either now or later from Dr. Griffiths. Just to also say that the two charities that benefit, are the Orchid charity and also the Africa Cancer Action Trust. So thanks to our accountants. And then on to the next page, because Dr. Griffiths also currently wears at least 3 hats for the organization. And so the website is working well, and we're using it for booking courses and keeping the membership list. But we do realize that we need to update it, and we will be working with our IT support from Mr. Barry Palmer, and to whom we offer our thanks. And also for membership, currently we have 320 members registered on the website. By far most are associate members, but there is an active option to upgrade to a full membership for a very a nominal fee of £10. And I think some of you have paid it, but if you would take a moment to do this when you have the opportunity to do this, that would be great. And the intention is to give full members voting rights if you have paid the £10, and also a discount on the courses. So thank you, Dr. Griffiths, for submitting these reports. And then I think we're on to the education report from Dr. Lisa Browning. Lisa, over to you. Thank you.
Thank you, Ash. Yeah, thank you very, very much for handing over to me. So in terms of the education report, I think it's easy to say that it still remains a bit of a challenge to organise meetings and events in view of the ongoing COVID-19 pandemic, but I think we can celebrate the successes that we've had over the last year, and that we are continuing to offer our BAUP courses, which have been superbly organised and hosted by Murali Varma over the last 12 months, and they've all been fully subscribed. So we've had, these are the courses that we've operated over the last 12 months since the last AGM. So we've had 3 prostate courses, 3 bladder courses, and the kidney, testis and penile pathology course, which ran in September. So although most of them were virtual, there was a welcome return to in-person events with the hybrid courses, prostate and bladder, in September. And the plan actually going forward for those bladder and prostate courses at least will be to offer them both in virtual and in-person events several times a year, because they remain popular and fully subscribed, and the virtual events allow us to expand our activities more easily outside of the UK. So thank you ever so much to Murali for his hard work in that, and to the co-organiser Dave Griffiths, and also for the kidney course to Dr. Hal Thomas as co-organiser for his hard work. So we were also delighted to be able to hold as a live event in November, the joint meeting with the BDIP, and we had about 200 delegates, or over 200 delegates, and were joined by internationally acclaimed guest speakers who gave an update across urological pathology in anticipation of the next WHO Blue Book. So for those of you who weren't able to attend, if you're a BDIP member, then those talks will be available to BDIP members after a 3-month period following the event. But for those who registered for the event, those recorded presentations are now up and available for you on the website. So in terms of what we're planning for 2022, thank you, John. The plans remain flexible in view of the COVID pandemic, but this is what we've got planned so far. So a bladder course in end of January, February, which is going to be another bladder course on a physical basis in May at Guy's Hospital, the prostate course in February, and a plan for a physical prostate course in September. And due to the demand for the kidney and testis and penile pathology course, that will be run again in March in person at St Hilda's College in Oxford. So that's what we're planning for next year. And again, as Ash said, if people have got alternative ideas or extra ideas about courses or educational events, then please do let us know. Thank you.
Thank you very much, Lisa. Nick, over to you for the EQ report.
Thanks, Ash. John's actually covered quite a bit already of this, so I'll in the benefits of time, go over this very briefly. So obviously there remain 3 of us organising the scheme. The SOPs were approved by the college in March 21. In terms of financing, which is held in the University of Leicester, as with BAUP, the accounts remain in a viable and healthy state. This report will go up on the website if you want to study the figures in detail, but we remain with a favourable closing balance there. As John says, we propose to take a PA out of the EQA and split between us for time in line with other schemes, and this will also help as part of succession planning when we eventually hand over the reins to somebody else, and I'll update the SOPs accordingly with that. In relation to us going purely digital, as John said, we'll go to a single one-off fee, which will be less than the current full participant, but a bit more than the colleague, and we can adjust that over time as we see what effect that has on the overall monies in the account. And the proposal would be to continue to subsidise future BAUP combined EQA meetings, as we've done previously, to keep the subscription costs of those down to a minimum for people. Next slide, John. So just very briefly, in terms of, we've now 4 full members with increasing numbers of trainees and overseas members. So please encourage your trainees to join the scheme. It's a useful thing, especially as they approach consultanthood. The most recent circulation we've just gone through, over 400 returns, and summarising the most recent previous 2 circulations in terms of action points. At the end of AA, 2 people triggered the first action point, no one the second, and in circulation AB there were no people triggering the first action point. So in the entire length of the scheme, we've sent a total of 16 Dear Colleague letters in total, so that's triggering the first action point, and no one's triggered the second action point. So it is a relatively uncommon phenomenon. And as John said, in terms of the meeting going forward, we'll probably be having 1 virtual and 1 in-person meeting affiliated with BAUP a year, as this format seems to work okay. That's just a point in relation to emails. Some of the EQA emails can go into the spam or junk folder in your email. If you're having trouble with that, there's a fix there which will be up on the website. And just the last slide, I'm grateful for Judy Wyatt. I showed this last year, and this is the updated chart, which basically summarizes all the EQA schemes and various data. And if you press the button once more, John, it's down in the bottom right-hand corner that I want you to pay particular attention, because if you look across all the schemes, the numbers of people triggering the first action point is very low. Nobody triggering the second action point. So EQA, hopefully that will reassure people that it's primarily for education, and that's certainly what most of us that are involved think.
Okay, Nick, thank you very much. And so really with that, is there any other business? Again, it's a little bit difficult to take on any other business unless you want to type that in the chat box. If you are still typing, I will just take a moment to announce the next BAUP meeting, which John has already mentioned will be sometime in a year's time. And if there are no AOB, then I would like to thank everybody for your attendance today, to the EQA team for all their hard work, and wishing you all a very healthy and safe festive season, and looking forward to seeing you next year. Thank you all.
Thank you, Ash. And with that, I think we'll close the meeting, if I can work out how to do that.